welcome everyone to our webinar on iron deficiency anemia. This is being presented between Stanford Obstetrics and Gynecology and CMQCC. We're so happy that you could join us today. We're very excited to present this work to you. I'd like to introduce the run of show today. Our first speaker will be Dr. Ira Igbinosa, who is an instructor and Werher Scholar at Stanford University. Then I'm going to speak as well on iron deficiency anemia, the problem. She and I will both cover that. Dr. Elliot Main will discuss some data elements that we have within the Maternal Data Center and why it may be important to capture those. And then finally, Melinda Kent of CMQCC, Associate Director of the Maternal Data Center, will present a lot of information about what the data center is capable of collecting vis-a-vis anemia and a lot of the cool stuff that we can do here. So again, thank you all for being here. We know that this is a very relevant, important problem in pregnancy, and we hope that you leave today with a better understanding of why we care about this and really what it is that we need to do to address this for all of our patients. A couple of housekeeping items. Please put your questions in Q&A. And also, if you haven't already done so, please mute your speakers. And without further ado, I will turn this over to Dr. Igbinosa, who will lead us off.
Good afternoon, everyone. I'm Ira Igbinosa, and I'll go ahead and get us started talking about iron deficiency anemia in pregnancy. So this is just kind of a general outline of the topics we'll be talking about today, from definitions, the impact, understanding the consequences to the mom and baby, management, and then what's next. So just starting off, iron requirements in pregnancy. This wheel on here shows the total iron in body determined by intake, loss, and storage. This wheel on this diagram shows that the iron needs increase as pregnancy advances. Things that we know that can cause iron deficiency are menses. And then we know in terms of pregnancy that iron requirements increase because there's an expansion of maternal red blood volume and red cell mass. And then it also increases in our placenta to support the fetal red blood cells. And so I think of it as a spectrum. There's iron depletion, you lose your iron depletion, one becomes iron deficient. And then in terms of there's iron deficiency anemia. 50% of healthy primograds are, in terms of first-time pregnant moms, have minimal iron stores in the first trimester. And 35% in the US are considered iron deficient early pregnancy. And so this diagram here is, I really like it because it speaks to how common iron deficiency is. And so this is a study of women who received care in a high resource setting. And we see that 50% in the top line of pregnancies were affected with iron deficiency. 25% of pregnancies had severe iron deficiency. And then most importantly, at the end, there were 40% of pregnant women who weren't even screened for iron deficiency. So something that's a really common problem, and what you'll hear is like, why aren't we screening about it? How can we improve in that regards? And so in terms of how common is anemia in pregnancy, globally, it's about 40%. In the United States, depending on aggregate reports, is anywhere from 12 to 17%. The prevalence is highest amongst Black pregnant people, from 18 to 24%. And here again is just kind of another way to think about the cycling of iron throughout a reproductive life course in terms of menstruation. You can lose some iron, but you see here this, I hope you can see my arrow, in terms of the iron needs. And then with pregnancy, it really kind of ramps up in terms of what you need in terms of iron. And so this kind of average pregnancy needs about 1,000 milligrams of iron. And often we're not getting that adequately through our diet and through our stores. And so why does anemia matter at delivery? So we know that for people who have more anemia at delivery, there's a 6-fold increase in major maternal morbidities. That could be placenta abruption, hemorrhage, infection, preeclampsia, prematurity. We also know that uterine blood flow increases about 5-fold in pregnancy. And postpartum hemorrhage, in terms of when we say it can be audible, you can hear the blood loss because it's think of like kind of wide holes in terms of bleeding, in terms of vessels. And so if you're starting at a lower level, then you're more at risk of getting more to that severe range and severe consequences very rapidly. And so thinking about what are the drivers of anemia? So we know there's obstetric comorbidities, that could be hypertension, diabetes. We think about social determinants of health, where people work, where do they play, education, insurance, country of birth, prenatal care. We know that 1 in 10 participants in WIC have anemia at the start of prenatal care, and often that increases by their 3rd trimester, where some reports up to 50% have anemia by their 3rd trimester. And we also know food insecurity is a correlation with anemia. And then there are racial and ethnic disparities, structural inequalities, and structural racism that contribute to this problem. And so speaking more on the racial and ethnic disparities, we know that Black pregnant people have about 2 to 4 times higher rates of anemia compared to white pregnant patients. And that's Hispanic, Latinx, or Latinx patients also have 1.5 to 2 times higher rates of anemia. And anemia can exacerbate other disparities. And so when we think about anemia and severe maternal morbidity being a near miss, an almost a death, if you will, is increased for those who have anemia, regardless of social demographic factors such as insurance, timing of care, and all those other things that you might think may come into play. And we know that severe maternal morbidity increases the risk of death. And in terms of a larger picture of disparities, Black pregnant people often are 3 to 4 times more likely to die in childbirth for very complex reasons, and a lot of them linking to social and structural issues in our country. And so some of our work from our group is just looking at, what are the trends of anemia in California? And so you can see here that for almost 10 years, anemia increased for everybody. And then on the top line, Black pregnant people have the highest prevalence, so almost about 20%. And that's a little bit higher than some of the national averages. And then followed by Pacific Islanders, also known as Native Hawaiian or other Pacific Islander group. And I think what's unique about this data is that because of California's diverse population and our data set, we were able to stratify by more groups than usually you're able to see. And then third, we see multiracial, followed by American Indian, Alaska Native, and then Hispanic. And so some more of this work, and I'll walk you through this graph. The key point is anemia contributes to about 1 in 5 cases of severe maternal morbidity, those at near miss, among Black and Hispanic patients. And so by race and ethnicity, we look at this adjusted population risk percentage, and that just tells us how many people in this group are having severe maternal morbidity because of anemia. So among our American Indian, Alaska Native is about almost 20%. Among our Asian Pacific Islander group, about 13%. Among Black, about 23%, Hispanic, 21%, and so forth. And so then the other thing is, you might be asking yourself, well, does severity of anemia matter? And what we will say is yes, but yes and no. So even at mild levels of anemia, at a hemoglobin of 9 to 10.9, we see there's still increased risk odds of a blood transfusion, almost a 2.5 times more risk of a blood transfusion, excuse me, compared to those who do not have anemia. And that we see that risk of blood transfusion really increases the more severe the anemia becomes. So the hemoglobin becomes between 7 to 8.9. We see those odds of intrapartum, postpartum transfusion go to almost 22, increase by 22 times more. And anemia doesn't just affect blood loss, it is also correlated to postpartum depression. And just walking through this diagram, this is several studies where they looked at the correlation between anemia and postpartum depression, and you can see how many studies are above 1, showing that there's almost a overall 50% increased risk of depression with anemia. postpartum depression. And then we also want to highlight that it's not just a maternal issue, it generational impacts. It affects iron deficiency in the fetus, the newborn, and the child. And so in terms of a review over 117 studies, 4 million pregnancies, we saw that maternal anemia was linked to preterm birth, low birth weight, perinatal mortality, and stillbirth. And then in this diagram here, it correlates what was those risks with the hemoglobin. So you can see here at the bottom is the hemoglobin. As we lose more of a hemoglobin, more red blood cell count, the risk of low birth weight, perinatal mortality, meaning infant death or small gestational age or preterm birth, all of that increases the more that our anemia increases. And then there are even studies to show that anemia in mom affects neurodevelopmental outcomes in the newborn, where there is correlation with poor recognition and memory, planning and attention, motor function, depression, anxiety, and autism spectrum disorders. So there's a lot of conversation in this space in terms of mother's anemia has a correlation to infant outcomes and childhood outcomes. In terms of defining anemia, I mentioned it a little bit earlier, but there are different definitions. And so generally, the WHO says a hemoglobin less than 11. The CDC has a different, CDC and American College of OB/GYN said it's in the first trimester less than 11, and the second trimester less than about 10.5, and then third trimester less than 11. And then the British Society of Hematology and the Royal College, they have a less than 10.5 after 12 weeks and 10 postpartum. So different variations by society guidelines. But who should be screened? There's general agreement that everyone should be screened at the start of prenatal care, and that approach should include CBC, can include iron levels, ferritin, smear. I have here highlighted hemoglobin electrophoresis. It used to be recommended by race ethnicity-based screening, but recent guidelines actually recommend that universal screening of looking for sickle cell thalassemias for every pregnant woman. And so here's just a quote from ACOG that the initial evaluation of pregnant women with mild to moderate anemia may include medical history exam and the blood indices that we listed above. And so how do we get to that iron deficiency component? And kind of a gold standard is looking at a serum ferritin. Ferritin less than 30 can confirm the diagnosis of iron deficiency anemia, and response to treatment can be seen about 3 weeks after treatment. One red herring is that it can be elevated in those who are sick from something else, have inflammatory illness, and so you might need to use something else to diagnose iron deficiency anemia. And transferrin saturation is one of those alternatives. With a transferrin saturation below 20%, that can be evidence of iron deficiency, whether or not the ferritin is low or normal. And so then just thinking about our cutoffs, just prior to 2020, there were race-based cutoffs on anemia and not based on anything biological. But prior to 2020, the guidelines said if one was Black in the first trimester to get treatment for anemia, they would need to be less than 10.2 compared to a non-Black counterpart who would need 11.1. And then you can just kind of see, again, in the second trimester, they would need a 9.7 as opposed to one who was non-Black with 10.5. And there's been studies that show that that this was linked to not only disparities in who received treatment, but then if you imagine somebody is showing up with pregnancy with lower hemoglobin, then they're at higher risk, 3 times higher risk of having a blood transfusion. And so this was recently modified in 2021. And then I will turn it over to Dr. Lau, who will talk about the management options.
Great. Thank you so much, Dr. Igbinosa. And as she said, I'm going to talk a bit about issues of management, also of treatment, and work that we at Stanford are doing with other providers throughout the state. There's a group of us I'll be talking about to overcome this problem, and we're partnering with CMQCC through an NIH-funded grant, and we're really hoping to reverse a lot of what Dr. Igbinosa has just shown you. I should also have mentioned that I am the new co-director and co-PI of CMQCC, and very excited to have this opportunity to talk to you all today. So I think I want to just start by kind of highlighting what may be a little bit of the elephant in the room. That there was a recent United States Preventative Service Task Force statement that reiterates what they've said in the past, but this gets thrown around and quoted, so I just want to bring it up here. So essentially, they concluded that current evidence is insufficient to assess the balance of benefits and harms from screening for iron deficiency and iron deficiency anemia in pregnancy, as well as to treat. And I think it's really important to keep in mind what these task force recommendations reflect. They're very focused on randomized controlled trials, and that is a level of data that in this space is going to be really unlikely that we're going to see when we talk about some of the differences that Dr. Igbinosa raised around how does this affect SMM? How does this affect some of the terrible outcomes that we really care about? How does this affect newborn? An RCT would take a lot of time, a lot of money, and we are not likely to see them. And I think when you look at the data, though, there is a lot of retrospective data that really suggests that iron works. In fact, there's a Cochrane review that suggests that iron supplementation can reduce maternal anemia by 70%. It can reduce iron deficiency at term by 57%. We know there are a lot of other studies that really link these to harmful outcomes and harmful practices. This is not rocket science, and this is not something that is really going to be undone even by an RCT. So we have very good reason to screen, to treat, to really pay attention here. Yet if iron treatment works, I think it's important to ask why so many people still have iron deficiency and iron deficiency anemia, because our professional societies say that we should be screening, we should be testing, and yet we still have some pretty major gaps here, as Dr. Igbinosa highlighted. Some of this is because some patients are refractory to treatment, some are untreated, and some are incorrectly treated. And that really falls to all of us who see our patients. So let's go on to look at one study that I think really highlighted this. This group, I believe at Baylor, led by Dr. Sarah Detlefs, looked at iron therapy outcomes in their own practice. So they basically looked at a bunch of charts, about 7,500 of patients who actually had anemia, and they had iron deficiency anemia, and they looked at what happened. So first, just about more than a third were successfully treated. About 8% were refractory to treatment, meaning that in the charts, it was documented that they were treated, and yet at their birth admission, when they came in to have a baby, when that tank, should be really filled up, it wasn't. They were still anemic. What's a little scary here is that almost 50% were untreated. So they got nothing. They had documented iron deficiency anemia, and they got nothing. They were not treated. They were just, maybe people talked about heartburn and other issues of pregnancy, but this important medical issue was ignored. Let's look now at what happened to the group who were successfully treated. This Detlefs et al. showed that this group actually had a lot less preterm birth, about 40% reduction in preterm birth overall. And that was a combination of less preterm labor and less preterm premature rupture membranes. So that's some pretty good solid evidence of treatment actually being helpful. There was also a reduction in preeclampsia. We worked so hard to reduce that. And here it is, and others have shown something similar. The refractory to treatment outcomes were similar to the group that was entirely untreated. So this is the group that they tried to treat, at least if you read the chart, and that's what the chart looked like they were doing. And yet their outcomes were just as poor as the ones who were not treated at all. It's hard to know if this refractory treatment was truly adequately treated and they just didn't do well. The group acknowledges a few things that are opportunities for all of us. There was lack of a treatment protocol. And this leads, we know, to potential for incorrect treatment, incorrect advice. There was lack of follow-up to assess whether somebody who was being treated was actually responding to iron therapy. Not everyone responds. I'll talk a little bit about that later. And there may have been undiagnosed secondary micronutrient deficiencies. We know that 70% of anemia in pregnancy that's non-hereditary, so not sickle cell, not thalassemia, about 70% is due to iron deficiency. So that leaves a whole bunch of other possibilities. Sometimes it's bleeding. Somebody has chronic abruption and they may just lose a lot of blood. We know that B12 and folate are possible causes too. We don't see a lot of that, but it's out there and should be screened for, particularly if somebody is refractory. So we have a couple of big challenges here that I think you're all aware of. One is oral supplements. So oral iron is readily available, but the uptake is limited. How many people get it is limited, and it's often given incorrectly. There are a lot of side effects too. And then another challenge is that there's a lot of lack of awareness of iron-rich foods and foods and medications that may impair iron absorption. So maybe somebody's doing the right thing, and yet they're not doing enough of it. They're not talking to the patient about what else are you taking with that medication that could be hindering all this hard work. And we'll dig into that a little bit more. So we know that pregnant patients require about 30 milligrams of elemental iron daily. You get in prenatal vitamins, a pregnant person gets in prenatal vitamins a little bit of what may be taken up by her blood volume and the fetus. We know that that's often not enough. We also know that absorption of oral iron is poor. Only about 10 to 15% of oral iron that's ingested is absorbed. And this can be a real problem if someone really has a pretty big iron deficit, they need a lot. We know that it's hard to get a lot of that orally. And side effects are very common. They are compliance limiting. Patients may not tell us that they may not be taking it, but GI upset, constipation, they're very common. So I know in my own training, I saw this, that when somebody came into the hospital, maybe she was on our antepartum service for a while, and she was very anemic, somebody would, say, well, let's give her iron 3 times a day, kind of thinking more is better. We know that more antihypertensives can bring down blood pressure more. Is that true with iron? No. More is actually worse. We know that if you give a lot of iron, you're actually going to decrease absorption. And this is a tremendous problem, certainly in terms of compliance and side effects. You're going to worsen a lot of side effects, and you're not benefiting anything. There was a really nice randomized controlled trial of this that looked at giving somebody 1 versus 2 capsules of ferrous sulfate, the most commonly used formulation of oral iron. And after 18 weeks of treatment, there was absolutely no difference in hemoglobin or ferritin levels between these groups. So the group that took 2 capsules is going to feel a whole lot more side effects, and they're not feeling good, and that might change their compliance, but it's also just not that helpful for someone who's dealing with everything else in pregnancy to have those side effects. And they didn't get the benefit. We think that this has become, and actually it's been shown that this is in part because higher levels of iron will actually inhibit absorption. That you increase something called hepcidin, which is critical for absorbing iron. And you increase it in a way that it actually reduces how much one's body is actually seeing. I mentioned the side effects and compliance, but it is reasonable to start with every other day oral iron as a regimen. That's my go-to practice in clinic. I'm in clinic this afternoon, and have moved away, and a lot of us have moved away from giving daily iron simply because if your benefit is going to be the same, you'll have reduced side effects and possibly better compliance and just more comfortable patients. We will often start with 1 tablet and then consider increasing to 2 every other day if there's no improvement. Let's talk a little bit about IV iron. So intravenous iron is recommended for patients who cannot tolerate oral iron, who may have a malabsorption syndrome. So this might apply to our patients, say, with a Roux-en-Y surgery, different conditions like that. People who have severe iron deficiency anemia as well, you can really get a lot more into somebody through the IV. IV preparations are generally considered safe. And I think it's important for those who've been practicing a while, who might remember the days of the first generation IV irons, that high molecular weight iron dextrans had much higher risk. So there were side effects that were frightening and dangerous. There was more potential for conditions like anaphylaxis. The newer generations are formulated differently. There's a tighter iron binding complex. They have a much better safety profile. There is a reaction that's important to know about. It's called the Fishbane reaction. It happens in about 1% of cases. It is not an allergic reaction. This is a condition, it's like a side effect where people can feel chest tightness and joint pain. And I think, we all get a little bit nervous around chest tightness because this, raises the concern, could this be someone who's going to have an anaphylactic reaction? So this is why we monitor patients during iron. And by monitor, I mean blood pressure, having a nurse around, having somebody who can pay attention to them. And it's important to distinguish this reaction from, anaphylaxis, which would be characterized more by wheezing, laryngeal edema, hypotension. But it's typically the fishbane reaction, and anaphylaxis from the newer generation preparation is really thought to be quite rare. There are multiple randomized controlled trials about IV iron currently underway. Or completed. A lot of them have been done in low-income countries, some in middle-income countries. There's a lot of variation in starting hemoglobins and IV iron dosing that's been being used, so they're a little tricky to interpret. There are some US-based trials right now, and Dr. Igmanosa is just completing one, and we're analyzing it and hope to have results in the fall. Our national guidelines really support the use of IV iron. ACOG and the Royal College of OB/GYN both support it. U.S. Preventative Services Task Force reports that data are insufficient, but again, they're looking to a different level of the randomized controlled trial. ACOG just has a general supportive statement. Royal College of OB/GYN makes an additional statement that IV iron actually should be used if someone's hemoglobin is less than 10 and this patient is after 34 weeks. And that's just based around the notion that it takes a while for iron to be absorbed and then blood to be produced. And these are patients who are getting much closer to delivery. They don't have a lot of time to overcome their anemia, and they really need it a bit quicker. Some additional considerations, there has been a small, but it looks like real increase in the risk of infection with IV iron. In a very large systematic review and meta-analysis of 154 randomized controlled trials, there was about a 16% increased risk of infection. I think it's important to note that there is a wide heterogeneity in these studies. These are populations of adults who received IV iron in a lot of different conditions, many not pregnant. And some of these, or many of these, were in malaria endemic countries, and they may not be completely transferable to what we have and see here. It's also important to note that with IV iron, you don't want to overshoot. So we talked about, little is good, a lot is not necessarily better. High maternal hemoglobin, so greater than 13, like trying to correct to that level, has been associated with increased odds of SGA, or small for gestational age newborns, stillbirth, preeclampsia, and gestational diabetes. I think it's also, finally important to note that nutrition is an intervention. So when we think about nutrition as an intervention, we know that there aren't great studies of nutrition alone as an intervention. So we don't have really great data there. But there are a lot of really fantastic dietary sources of iron. I've listed here plant-based and animal-based. So enriched cereals are among the highest, soaked beans and lentils, leafy greens, tofu, and so on. Animal protein has the highest amount of iron in this order. I think it's important to know, like, a lot of people may not eat beef, and so there are other formulations of animal proteins if they eat them: chicken, turkey, fish. Eggs are also a good source. They're a little bit lower on the list, but they contain iron and they help. It's also important to avoid foods and medications that impair iron absorption. And I can think back to my own training, and I think a lot of people in the audience who may give iron out, we don't necessarily learn this, but dairy and soy products and egg yolks taken sort of with iron might actually work against absorption, as does coffee and tea. Calcium, so Tums, milk, products that a lot of our patients may be using. You don't want to take those with iron. There are also foods that might help with absorption, though there's some mixed data here, but vitamin C is commonly thought to be helpful. So commonly found in like orange juice in higher concentrations, or tomatoes. There is one study that really puts this into question. For those interested, if you go to WIC and WIC websites, they have a lot of excellent information there, patient-facing information. WIC Los Angeles, I've included the website address here because they've got some really nice materials on this that I think are helpful to not just patients, but providers. So I want to switch right now. I've mentioned some of the ongoing research. Just to set the stage for that, as has been said, anemia contributes to upwards of 25% of cases of severe maternal morbidity. And we know that iron deficiency anemia is preventable. And yet we still have so much anemia after 7 months of prenatal care. So why is that? Some of it we can easily recognize, as I've shown from the Detlefs trial and others. I think that we know that this is under-recognized as a problem by providers and also by patients, that our current screening approaches might inadequately prevent anemia at birth admission, or actually they do, because we do have this problem. So we need better approaches. Sometimes our approaches to evaluation and treatment are inadequate, and treatments are not easy to take. We're not the only ones who are sort of viewing this as a problem. If you look around in the literature, this is something from the American Journal of Public Health, written by epidemiologists from the CDC, among others, that they really called out in 2022 that the foundational guidelines influencing clinical practice recommendations to assess and diagnose iron deficiency need to be updated. They're very old. They don't match kind of our society, population, diet, lots of different things today. They call out that given the age of the CDC guidelines, the available evidence relevant to the assessment and diagnosis of iron deficiency warrants revisiting these guidelines. So our challenge is pretty basic. Our current approaches are not working. And it's important to note that we think back to the tremendous disparity in outcomes here, that we don't even have any studies that consider the perspectives of Black or Hispanic Latin women on iron deficiency anemia in pregnancy or pregnant patients. We know that maternal anemia is an important driver of things like transfusions and other maternal and neonatal complications. And we think that one great way to solve this is to work with patients in the communities. First, assess their understanding of anemia and iron treatments. We can then design better messaging and better approaches to treatment, trying to understand the problem from the perspective of those most impacted, but also to work with providers, all of us, to create and implement better protocols in provider education and then patient-centered solutions. So we've done some of this work. We had a grant at Stanford that I was a part of, and Elliot Main, as Ira Igbenosa, Susan Perez, and others. It was basically a community engagement project to really develop start this process of developing a patient-centered approach to anemia in pregnancy. We partnered with Black Wellness and Prosperity Center, led by Shantae Davies Bulch, and with BWPC, she and we convened an anemia community leadership group. This was a group of women with lived experience of anemia during pregnancy, and really dug into understanding what was their knowledge and experience, what were the things that they were hearing and being told and whatnot in clinics. Our goals were also to understand and identify patient-valued outcomes, what mattered to them, to then over time review and modify our patient education materials because they, in many cases, are lacking, and then ultimately to explore patient satisfaction and experience. And the overall goal is really to generate patient-facing tools. There were several themes that emerged from this work. We found that there was a real lack of information and education from the providers regarding anemia, and we're not there in the room listening and all that, but I think the take-home message is if you have somebody who had anemia during pregnancy, who said, I don't understand what I had and how it was important, that's a problem. And so however it was communicated wasn't getting through. There was a perception of just dismissal of the patient-reported symptoms. There were definitely treatment challenges around nutrition and oral and IV iron. There was a perception that race and culture were contributing factors to maternal care. And finally, a very strong desire and need for more patient-centered care and information. People want to do better. They want to take good care of their babies. They want to feel good and do the right things. And yet a lot of this was not being adequately transmitted to them in prenatal care. Dr. Igbinosa presented this work at the Society for Maternal Fetal Medicine annual meeting in Maryland in February, and we are excited that we will soon have a publication on that. So moving now toward our kind of current project that we're going to talk a little bit more about. We at Stanford received NIH funding in order to basically move this project forward, where we are focused on patient-centered community and clinical approaches, combining those to reduce the racial disparities at birth by preventing anemia. We have a community and clinician leadership group. The community group is here. This is Shante Davies-Bulge and Kata Nemeth. This is Susan Perez, who is our Dr. Perez, who works between both the community and the clinician group. I haven't shown everyone in our clinician group. These are a lot of the folks who have been coming every month for almost 3 years, talking about anemia from our perspective, helping to work on better protocol that we will roll out, and I'll talk a little bit more about soon. This is our project overview. It's for 7 years. I'll come back to this in a minute, but we are solidly here in AIM-1. So working with BWPC and our clinician clinical leadership group, we are working to create a toolkit ultimately that's going to help all of us to manage this problem better. Want to focus a little bit more within AIM-1 because this is where we are. We are in working with BWPC, we've convened an anemia community leadership group. So this is people with lived experience, and we are using the public health critical race practice framework, as well as pathways to racial and ethnic disparities in severe maternal morbidity and mortality model. And our purpose again in AIM-1 is to create this toolkit, and it's one that we want to align both evidence-based practice, that's what our clinician group is working on, but with patient-centered care, really incorporating people's lived experience, community assets. So where do people get messaging? Where do they, get support for this being a problem? And also clinical and hospital workflows. I've mentioned that our clinicians are working on a protocol, education, computer-based tools, and then utilizing the maternal data center and data collection for measurable outcomes that we'll be able to track over time. And that's something that Elliot will talk a little bit more about, and then Melinda can. And that's where this is exciting work for everyone here, because there's a lot more that you can do as well. We're doing a lot of focus groups currently, trying to understand this problem from a lot of different perspectives, including those of people in clinics, as well as all our patients and providers. Again, this is the 7-year overview. Our second aim will be to pilot this work, and we have 9 pilot hospitals where we'll be piloting our intervention. We have a clinical protocol that really kind of lays out what the targets are, what labs are, when do you draw them, when do you follow them up, what to do if the hemoglobin is within different ranges. I'm not going to show that today, but we will certainly hope to come back and present this work over time. We're going to modify our work based on what we find in our pilot protocol before we roll this out at scale in the form of a toolkit. So just to summarize some of the key gaps that I've covered, that we have a lot of issues around inadequate messaging of the importance of anemia in pregnancy. This is something that is felt by patients, but I think that we can see among providers as well, when up to 50% sometimes are not even treating anemia when they've identified it. We know that there are existing health disparities here that are really not okay, and that they mirror SMM rates, and that this is a real opportunity for us to improve outcome for all. But that we're missing patient perspectives, particularly among racially and ethnically diverse groups that we have in our patient populations. We have inadequate guidelines for screening, for treatment, and for ongoing follow-up. We often give incorrect advice, and we may have suboptimal knowledge. Our patients as well. And sometimes the best methods for treatment may be unclear. And then finally, there's a real lack of access to IV iron. I know that some of you feel it. We've heard it in our clinical leadership groups. We've explored this, and there is an access problem to IV iron. Some of us are lucky and we have easy access. Many of us are not, and it's a real challenge. So with that said, I'm going to turn over the floor to Dr. Elliot Main, who's going to discuss measures for prenatal anemia for prenatal anemia initiative.
Thank you, Deidre. But before we start, I'd really like to emphasize one of the key points earlier, which is the focus on iron deficiency as well as iron deficiency anemia. As Zero showed earlier, if you're iron deficient to begin with, you have a really, really high chance of having iron deficiency anemia by the end with the iron demands of pregnancy. And that's where we have a real opportunity to be working earlier in pregnancy. Next slide. To improve care, though, you have to have data. Just like we were able to improve care for reducing NTSV C-sections or episiotomy rates, it's been with data feedback. And that's really one of the key goals that we have for the project and for the state as a whole in the Maternal Data Center, which is to be able to give feedback to physicians and to practices about what their proportion of patients who enter labor and delivery with anemia. Anemia defined as either mild anemia, 10 to 11, moderate anemia, 8 to 10, or severe anemia under 10. And that is a simple data point shown on the right side of the first hemoglobin collected during delivery admission. This is going to be a key summary measure for the entire project. This is sort of the summary of what you've done for the last 7 months in prenatal care. What proportion of your patients are showing up with significant anemia? We don't know that. No one has really been paying attention to this. This is the real opportunity, I think, of this project, is to really get a handle on the proportion of patients who have gone through pregnancy without really having attention paid to care of their anemia. Next slide. So then the first slide showed an intermediate outcome, which is anemia on admission. But what about the consequences of that anemia? And there are a couple of measures that we have that really can tie that together. One of them is increased risk for blood loss. It is interesting that data is now showing that patients with low hemoglobins actually have higher blood loss at delivery, i.e. they're more at risk of blood loss, even though they have less blood to begin with. And this is where we really want to be able to tie the quantitative blood loss at delivery or during the entire birth admission to their degree of anemia. And so these are data elements that are going to be in the data center for QBL over 500, over 1,000, over 1,500. And this will be able to put that together to show what kind of outcomes you get with the degrees of anemia. Next slide. In a relationship, in another sense, is looking at the need for transfusion. We have transfusion in the data set as a yes or no, but that's really been inadequate. We're really drilling down into severity, because 1 unit of blood transfusion is not nearly as significant as 2, 3, or especially 4 or more. And so we really want to be able to track the number of units transfused. All of these measures, the the hemoglobin on admission, the QBL, and the ARTS are going to be available as supplemental data submissions that will be gone over by Melinda Kent and the MDC team in a few slides to follow. Next slide. This is really going to end up being an important part of this picture, because we really want to be able to tie the anemia measures to the prenatal care site, because that's where you're going to get your feedback, because this is obviously an event that occurs during prenatal care, not at delivery. The data center already has the ability to identify each patient's location of prenatal care. And this is something we want to beef up throughout the state to show so that the results can be shared back with the clinic or the office to give them feedback onto the quality of the care that they're providing during the prenatal period. Again, this is going to be a real important thing that we want people to focus on. Next. We have other outcome measures that are tied to anemia that are already in the maternal data center. Eero talked about severe maternal morbidity. That we capture it in several different flavors, with and without transfusion, and with and without adjustment for comorbidities. So this is again going to be we hope to have to show that prenatal care can affect severe maternal morbidity, can improve severe maternal morbidity. Hospital length of stay, the sicker you are with severe maternal morbidity, the longer your length of stay. So this is also going to be a sensitive indicator for anemia. We anticipate that we can stratify with data already in the data center for important cofactors, such as the difference between a nullip or a multip, by race and ethnicity, by prior C-section, among others. So these are all going to be important factors for anemia. And as a teaser, I want to, in red here, I want to say stay tuned for the ability to capture readmissions after delivery in the MDC, in the maternal data center. And I think this is going to be an engaging piece that's going to be of value for all the QI projects that we do. We have a few minutes. Deirdre, do you want to address some of the questions that I haven't had a chance to at this point before we go on?
Yeah, so there are a couple here on IV iron. Since Eero just ran an RCT on this, she's truly our expert, and so I'd like her to take those.
Hi, so I'll answer the first one. It says, I'm interested in workflows for ambulatory IV iron. Our health system has closed infusion centers and we have access issues. So that's something we're working on with our community group, our community clinical leadership group. And I will say that there are different options for IV iron, often, which kind of gets a little bit at the second, Courtney's question, that can be given faster. And so some of the traditional IV irons are iron sucrose, which take a few hours to give, but some of the newer ones are safe, have even lower anaphylactic reactions. And so that's some of the things that we've been investigating. If for people who don't have access to infusion centers, could it be done in a triage setting or something like that? So more to come there in terms of, identifying a best practice workflow if you don't have access to an infusion center. And then in terms of the second question, the research on the side effects and fishbane reactions at various infusion rates with iron dextrin, like NFED, I think that's a great question. I can tell you what we know is that there's some serious adverse reactions, the anaphylactic reactions are less than like 0.001% with NFED. But the fishbane reaction, which Dr. Lau had mentioned earlier, is kind of like where you have the flushing and everything is very transient. And so there are some, in some of our research, we've shown that if you're able to slow down the rate than what is from 15 minutes to even 30 minutes to an hour, then you significantly decrease that risk of having a fishbane reaction. And so that's one of the things that we will be suggesting and come up some of our protocols that talk about how to use other IV irons. And I think I see one mentioned. Yeah, so Vinifer is kind of the most commonly used, but it does require multiple doses to get to, I talked earlier, the average pregnant patient needs about 1,000 milligrams of IV iron. And if you calculate that need to get to just to an 11, you're looking at 3 or 4 doses of Vinifer. And so that's why there's been so much research in, can we meet that deficit with some of the newer IV irons that have been demonstrated to be safe in pregnancy. I think there's one more. In the postpartum period, would you ever transfuse IV iron with or without blood transfusion? I think that's a good question. I will say that the cutoffs for how people define anemia varies in the postpartum, because now at this point they've delivered, and we're trying to what outcomes are we trying to help with? And so for some places they define that as a hemoglobin less than 10. And as is what defines anemia. And then for the lower levels, in terms of severe, moderate, IV iron is an option to potentially not even needing a blood transfusion.
So one of the joys of running a collaborative is to be able to collect multiple ideas about how to improve care from people in the trenches. For example, one of the places that some hospitals are using for administering IV iron is antepartum testing, which is typically not very busy on Wednesdays with twice a week testing. I know Monday, Thursday, Tuesday, Friday, those are typically open days. And so we anticipate getting a lot more ideas, such as what was suggesting around prehydration and others that we'll be able to share going forward. In terms of some of the data questions here, we do capture in the maternal data center the amount of prenatal care that the patients had, so we can stratify out those who had no or under 3 prenatal visits, particularly as you do analyses. And we already are doing prenatal care group analysis in the maternal data center so that we can give groups their rates for C-section or their rates for episiotomy or their rates for multiple other measures. So this would be added to that, but the hospital needs to assign doctors to prenatal care groups. And there are some ways to figure out issues around midwifery in hospitals as well. So stay tuned for that, but this is going to be an exciting way of really giving some data back to prenatal care providers. There's a question around Fairlicet infusions in the postpartum.
We haven't used Fairlicet as much, just because the preservative that iron is contained in there's been some question about the safety, but I presume it could be given in the postpartum period, because at this point baby's delivered and that thing should be fine. And so I think on the table we have a review that we include it in terms of the dosing, but it's not one that I have personal experience given.
Yeah, nor have I. I just want to add something else. So there's a comment about not having antepartum testing centers. That was just one idea. We've faced this struggle too of having patients come to our labor and delivery triage when we've gotten really busy. We used to let people be able to have people come to L&D triage to get IV iron, and at busy times it's just not tenable. I do want to highlight though one point, that people who are getting IV iron don't need fetal monitoring, and this is not, internally this is a process that we had to overcome, where some people have that belief, and then we could get pushback when we send patients to our infusion center, where people are getting other infusions. They might get IVIG and other infusions for different reasons, but that is one option in certain environments.
And then I could combine there's some good reviews that show that if you're able to treat the postpartum anemia, you decrease the risk of blood transfusion. And I see that, so you often, if you're treating it in the postpartum, then you're actually preventing them from needing a blood transfusion. And that information, as we collate it, could probably be helpful for those of you who are experiencing some pushback from your pharmacies from giving it.
I'm not certain there's great data here yet, but I think there's going to be an association between sending someone home with a very low hemoglobin and postpartum depression. Because if you're exhausted and even more exhausted, I think you're a setup for that. So I think we're going to need to pay attention to that aspect as well.
Yeah, I definitely agree. And I think Courtney's comment about the side effects, I will say we had to do a lot of education on telling people what is a side effect versus an adverse reaction. And I think once we really kind of clarified what was a true allergic reaction and like safety, it helped everybody feel more comfortable with it. And we actually didn't, our experience was similar to that literature in that we weren't having a lot of adverse effects. And often by just slowing the rate and stopping, there's little things like everyone doesn't need antihistamine before getting IV iron. That actually increases the risk of them having a fish vein or something. So there's a little there's a few things that we see that people do that increase some of those side effects. I think so. And then this last question, kind of grouping them together, has postpartum IV iron transfusion been helpful in those who had PPH? I would say it's in combination in what their resulting hemoglobin was in terms of their blood loss. But often if you're getting somebody potentially like a 7 or 8 and who's hemodynamically stable, you could give IV iron and potentially not need to also give blood. I think we reserve the blood transfusion for those are truly like unstable patients with low hematocrit.
But a hemoglobin of 10 is not going to need a IV iron, most likely.
Agree.
Yeah, and there's a question here about the prenatal care group and an interest in hearing our thoughts about how to communicate maternal data center data with the prenatal care group. So we haven't started this yet. I think, though, I would view this as very similar to how other data within any kind of system might be communicated back to groups. I think that, this could apply to however, say, NTSB data may be shared internally. I think that, data are important. We all think that we're doing, great, and that somebody else has the problem. And then you can look at your own data and just understand, how are your patients arriving at birth admission. So I would imagine sharing this among every group. And then whether or not you can drill down to provider, I think that every group is going to be a little different and have a different setup and have a different set of needs. And I think this is a nice transition into Melinda Kent and what she's going to share, because this will give you a better sense of what data we expect to have available. So I'm going to stop sharing the screen now. Elliot, final words.
So just to amplify that last comment a moment, we're probably, prenatal care is a group event, and it's a group among a group of physicians as well as the nursing staff, the administrative staff in the office. And we want everyone to be involved with improving prenatal care in that setting. So that's why we're really focusing on doing it as a prenatal care site at the office or a clinic, to get the clinic really organized to deal with anemia and all the tools that are being developed in this project. Thanks. So over to you, Melinda.
All right, thank you very much. I hope everybody's having a great day. Thank you so much to Dr. Ibnosa and Lyell and Maine for your presentation. It was absolutely wonderful. To piggyback onto the question about the prenatal care groups, having worked on the LDA project, I also saw some innovation with monthly or quarterly meetings being set up between the prenatal care groups and the hospital leadership, and that seemed to be helping with the transparency with the data and working together on the QI. So that's another recommendation that I have. So I'm going to go ahead and get started. And we're going to talk about addressing anemia in pregnancy and the key data elements and the CMQCC Maternal Data Center. So in the background, we have our MDC staff right now, and they are supporting this wonderful webinar. So thank you to all of them for your help. And it's a pleasure to be here, and we're really excited to be able to talk about what we can do within the Maternal Data Center to help aid with evaluation and quality improvement with this data. So let's start with supplemental data measures in the MDC. The supplemental data measures in the MDC are individual. There's only certain measures that require supplemental data submission before they can be calculated. About 80% of the measures are automatically calculated, but the other ones do need supplemental data submission. Today, we're going to review the importance of and how to submit supplemental data files for the following measures. For 1, anemia on admission, and 2, QBL cumulative value measures. The importance of tracking anemia on admission. Prenatal anemia, as we just discussed, is a modifiable contributor to severe maternal morbidity and other adverse outcomes as well. Prenatal hemoglobin optimization is highlighted strategy in the CMQCC Obstetric Hemorrhage Toolkit. Tracking hemoglobin levels on admission can help your hospital identify patients who should have been on prenatal iron regimen and review opportunities for improvement. So evaluating the data can be very, very helpful and very strong motivator for the improvement. Additionally, your team can identify how much prenatal anemia contributes to the facility's transfusion rate. So that's actually really wonderful that we have the ability to look at that. The importance of tracking the quantified blood loss, or QBL. The MDC has a hemorrhage frequency measure based on ICD-10 codes. So for example, 072.1 is other immediate postpartum hemorrhage. And this may not be perfectly aligned with the clinical threshold of 1,000 mLs for identifying hemorrhage cases. So for example, the 072.1 could be coded for other immediate postpartum hemorrhage because that's what's documented by a physician in the record, but then we see that the QBL is 850. And so by submitting the QBL cumulative value, this would provide the ability to flag cases that truly meet the clinical threshold for hemorrhage. So this is important for case review, QI, and analysis. For submitting supplemental data to the MDC, we're going to discuss a background real quick, and then we're going to get into the steps. So in addition to the required patient discharge data file for the MDC, hospitals also have the option to submit additional data via separate supplemental data files. So these are optional. Once the required PDD files are submitted, you can then submit supplemental files with any additional data fields at any time. So once the PDD is in, you can do it that day, you can do it a week later, 6 months later. As long as the data is already in the MDC, you can go in and you can submit that data. So the interactive supplemental data form will generate the following. It helps to create the supplemental data file for you. This is extremely helpful and really eases this process. So there will be a special notes section in the measure that you selected, a sample file with all the correct column headers to use that can be downloaded. You have to remember, for those of you who don't understand how the computer systems work and interface, if you don't have the exact title, it's not going to then pull into the field in the MDC, and it won't recognize it. So you have to use these exact column headers. So this sample file is super, super important. A data dictionary will also be provided that includes definitions of the data elements that will be needed. So these are the definitions for use within the MDC, and this is super helpful so that you know that you're getting the right information that you want. So you'll log into your CMQCC account, click Launch MDC, and in the top right corner, you're going to click on Data Entry Status. In the text above the table, you'll see that blue underlined link that says Submit a Supplemental Data File, specifications here. You're going to click on that. Then you'll get to this item that says, what do you want to generate a file for? Who do you want to generate a file for? So you're going to select your hospital, continue with the primary identifier used in the PDD file. So for some hospitals, it's medical record number. For others, it's account number. So it's the primary identifier. Some hospitals submit both, but you want to make sure that it matches up with the primary identifier. You're going to then see a box that looks like this, and it has use cases on the left and data elements on the right. And you can see at the top, this one says medical record number. So that was the primary for that hospital. That was a selection. And if you chose account number, it was the account number there. You're going to select the use cases groupings or the individual data elements to include, and then you're going to click continue. So on the example here, we see that the hemorrhage QI bundle is selected. And then you're going to use the CSV file format with each patient case as a single row. So each patient has its own row. You don't want to mix rows for patients. The file column headers, as denoted in the specifications, must be used for all fields you submit to the MDC or it will not work. And the supplemental data file generator in the MDC allows you to download a sample file, we talked about that a minute ago, that includes the exact column headers for the data elements you selected. So you can see here, we have in the green line, it says medical _ record _ number. So those are the titles that we're talking about for each column. And to submit your supplemental data file, once you have completed the Excel spreadsheet and you have all the information in there, you're going to go to the data status or your system data status, and you're going to click on the upload button. And then this screen will come up and you want to select maternal or newborn supplemental data files. They are different and we need those to be in different files. So if you're submitting for maternal and for newborn, they need to be separate. After they upload, the files will be found in your file upload history. You're going to click on details and then you can view your data value changes. If you needed to, you even have the option to undo changes to the entire file by clicking undo all changes. Or 2, you can undo changes to specific data fields in the event the file erroneously overwrites previously submitted values. So it's good to have those options and know that they're available. The MDC metrics will automatically update based on the uploaded values for cases in the supplemental file. So there's no more work that needs to be done after that other than evaluating your data. And you can see the user guide for the MDC optional supplemental data file specifications. There's one for California hospitals and there's a different one for non-California hospitals because the data is just a tiny bit different. So for submitting supplemental data for QBL cumulative value, QBL at delivery, and anemia on admission, we're going to discuss that right now. And you will notice that QBL at delivery, for those of you who do QBL, you'll notice that that is not in the MDC yet. That is something else that will be coming. So we're really excited about that addition too. So there's 2 main ways to submit data on supplemental measures to the MDC: manual abstraction or chart review, which a lot of them have, and then supplemental data file uploads. So for QBL and anemia on admission, the data file upload is the only option for data submission. There's no option to go in and do a manual abstraction or a chart review. You have to do the supplemental file. Let's talk about the cumulative value. So the QBL cumulative value is the cumulative amount of blood loss calculated through quantitative means through the birthing process. The denominator is all deliveries. Sampling is not allowed. And all deliveries can be parsed by category. They will be parsed by category. So you can see in the graph that we have, the bar graph on the right, the stacked bar chart, that QBL missing, not reported, less than 1,000 mLs, 1,000 to 1,499 mLs, and greater than or equal to 1,500 mLs. So this is a really exciting chart to look at if you're evaluating this data. It gives a lot of information. So step 1, if you wanted to create this file, you would go in and you would select QBL cumulative value from the data elements right-hand column. And then you would create your supplemental.csv file with the required data elements. So those data elements are the patient identifier, the discharge date, and then the QBL cumulative value. And you can see we have that picture there. So now we can look at our missing or inconsistent QBL values once that data is uploaded. The MDC will flag cases with missing or inconsistent values for cumulative QBL when compared to hemorrhage ICD-10 code. In a stacked bar chart form, you'll see hemorrhage diagnosis and QBL less than 1,000, no hemorrhage diagnosis with a QBL greater or equal to 1,000, and no QBL reported. This is another really good view to look at your data with. QBL at delivery will be coming soon, as I said. The definition will be the cumulative amount of blood loss calculated through quantitative means at delivery. The denominator is all deliveries, sampling not allowed. And the numerator will be all deliveries parsed by category. And once again, we have the same exact categories. So it's very much like the cumulative, but it's the delivery QBL only. Let's discuss anemia on admission. So the measure definition is delivery cases with anemia on admission to hospitalization. All deliveries for whom a hemoglobin value is provided is the denominator. So if the hemoglobin is not provided in the supplemental file, then it will not be on this chart. So just remember that it's important to have this information uploaded. If anybody has any questions about how to set that up, we can definitely work with you on that. You can contact us. So don't let this process scare you. A lot of hospitals out there are uploading information, and the first time that they set it up, they learn, and it's easy from there. So the denominator also excludes those with non-iron deficiency anemia. Actually, that's the measure definition. It excludes those with non-iron deficiency anemia based on the diagnosis and ICD-10 code. So that's important to know also when you're evaluating this data. The numerator denominator cases with a hemoglobin value less than 11. So like the numbers that we spoke about earlier, the doctor shared with us, less than 11, you will have the diagnosis based on these recommendations will be anemia, and this is what will show up on the graph. So to create this record, you're going to select hemoglobin value, hemoglobin, as you can see checked from the data elements right-hand column. You're going to create a supplemental.csv file with the required data elements, patient identifier, discharge date, and hemoglobin value. And then the data can be uploaded. After that, you can evaluate your missing, inconsistent anemia hemoglobin status. So the MDC will flag cases with missing or inconsistent values for hemoglobin value on admission when compared to anemia ICD-10 coding. And it's once again in a stacked bar chart format. And the categories are no anemia diagnosis, but the hemoglobin value on admission was less than 11. Hemoglobin value on admission greater than or equal to 11, but non-nutritional anemia diagnosis, and no hemoglobin value submitted. These are really, really good areas of data to look into. We're going to go over some quick MDC tips, and then we'll see if you guys have any questions. So making one-off edits. While a supplemental data file is the only way to get the QBL or hemoglobin values into the MDC for multiple patients at one time, you can modify these values for one patient, two patients via the case editing tool. And so the picture is here. You would click on the pencil, and then you would be able to go in and you would be able to edit those specific ones. If you go in and you select the hemorrhage QI bundle on the left side, the use case list shows that the supplemental data file template generator will create a document for you, and it will pull all the data elements recommended for that measure in the MDC that supports OB hemorrhage QI. So this is a really, really handy tool. So the left column, once again, that's the data file, or sorry, that is the use cases on the left side. If you click one of those, all of the recommended measures from the MDC that associate with that one or recommended will automatically check for you. So for the hemorrhage QI bundle, that's anemia on admission, hemorrhage risk assessment, QBL cumulative values, and transfusion measures. You're going to download the spreadsheet of the patient cases. On the top right corner, you can see download Excel. This drills down to a measures patient level screen and downloads an Excel spreadsheet of patients who make up the fallout cases. These cases are the ones who experienced an outcome that was not ideal. And it's really important to know that this is here. So if you click on the download Excel, like I said, you'll get an Excel spreadsheet. It will have all of that information, and you can further evaluate that data. You can use it to take notes. You can use it to share with other people on your team. This is a really helpful tool. The additional analysis outside the MDC, if you want, like a mean hemoglobin value, or if you want to know if there's a day of the week, you know, whatever it is that you want to know, you could go through and you can start looking at all of that information. If you guys have any questions, if you want help setting up your files, if you're trying to set up your file and then you just have a few little pieces of information that you need, please click on this Contact MDC Support. Use this button to ask questions of the MDC team for anything, not just this. But an example for even this or another measure would be, why is this patient included or excluded? We see those questions a lot. Do not send true patient identifiers. We don't want the MR number. We don't want the account number. We don't want any of that information. Use the encrypted version or row number where you are within the MDC, and then the program managers, we will be able to work with that to look at the patient information without knowing any patient identifiable information. So the data privacy is really important to us, and we want to make sure that we are all good stewards of this data. So thank you guys so much for coming today. Do we have any questions?
While you're thinking of questions, I'd like to make an additional point, which is, since the supplemental data is essentially extracts from your electronic health record, such as the first hemoglobin in the record, it's a simple matter of working with your IT. Now, nothing is simple working with your IT department, mind you, but once you get that established, it flows, and it can flow retrospectively. So one of the key things here is that you can set this up and get hemoglobins on admission for the prior 6 months or year, enter them into the data center. Now, all of a sudden, you have a lot of data to work with. You don't have to wait 6 months in the future. So we really recommend that you do this retrospectively to iron out the issues and to see where you stand yourself with your data on these issues.
That's a great point. Thank you, Elliot. Are there any other questions? If not, we'll go ahead and end this webinar. We thank all of you for coming. If you think of any questions, please send them in so we can help you. We're here for you. I do see one question. Let's see. Oh, thank you. Thank you, guys. You guys make this work so valuable, and we really appreciate partnering with you, and we love what we do. So thank you, guys, and I hope everybody has a fabulous day.